Continued ambiguity over the future of the SGR fix. Payer awareness of 340B's impact on drug prices. Changing deadlines for meaningful use requirements. How are the discussions and decisions in Washington poised to impact healthcare stakeholders? And what response should these stakeholders be considering? Join us to find out. In the Know starts now. Hello and welcome to In the Know, your source for insight and analysis on the issues that matter to our dynamic healthcare market. I'm your host, Gina Clark. Today we renew our periodic updates on legislative and policy changes that affect the healthcare community. We will address the latest on Medicare reimbursement for physicians and how bridge programs created under the Affordable Care Act may or may not serve as an indicator of things to come. We will also dive into drug shortages and see what our legislators can do to address this crucial issue. Returning to In the Know is Peyton Howell, nationally recognized public policy expert and president of AmerisourceBergen Consulting Services. Thanks for being with us again, Peyton.
Thanks, Gina, for having me.
One of the issues we have discussed with some regularity over the last 18 months is the Medicare payment to physicians and the ongoing debate over the SGR fix. Can you offer an update for how the discussions are progressing and if a more long-term solution might be on the horizon?
This has been an ongoing issue. It's been since 2003 that the sustainable growth rate issue has impacted Medicare physician reimbursement, really creating this growing, looming cliff of potential cuts in reimbursement. Last year, it took a patchwork of 5 fixes to be able to bridge and in some cases retroactively fix reimbursement for physicians. This year, we've got a fix until almost the end of 2011, which actually sounds like great news, but the reality is we're stuck in the same lurch that we've been in before, a potential of a 30% cut, actually, if this issue is not addressed before the end of the year. So we're in the same mode. Right now, in fact, just recently, the Congressional Budget Office did come out with some alternative recommendations related to what to do related to SGR. Most of them really recommend more short-term fixes, again, because of the cost of this issue and really trying to buy time in order to find a longer-term solution to better align physician compensation. But in the short term, this issue hasn't gone away.
From what you have seen, what impact has this continued ambiguity had on the provider and manufacturer markets?
There's no doubt about it, there's a psychological impact of it. And it's kind of interesting because in reality, we've always bridged payment, there's been no gap, but it has created this continuing stress and basically a very flat reimbursement level for physicians. And even though it's just for Medicare, so many private payers use that, as really a floor to look to, that it has been important for cross payer type. So there has been some stress, although albeit more psychological than real reimbursement issues. I think as providers look to this issue going forward, I'm hopeful that we're going to see some solutions that are longer term, because I think that will really make providers feel more secure in the reimbursement environment.
So while we're discussing physician reimbursement, what is the status of efforts to clarify or improve reimbursement under ASP?
We do have some progress this year on that, and I know that's exciting to say in a year where it's clear in Washington, D.C. it's hard to get almost anything done, particularly anything that might cost money. But on ASP, we've been able to reintroduce legislation to have distributor prompt pay terms excluded from ASP. We know that's an important issue because it would just make reimbursement more consistent. It would also align Medicare drug reimbursement with Medicaid drug reimbursement. So it's important from a policy perspective. Both the Senate and the House have introduced legislation to that effect. There is some movement and support growing actually for that legislation, and we're very hopeful that there'll be a vehicle, perhaps in the fall, along with other healthcare legislation that it might attach to. So we are hopeful to that, and I think it's important that we continue to remind everyone in Washington of how important ASP reimbursement is in general. We can't lose sight of that. The reality is reimbursement is very constrained. That's what has created some of the pressure and made some of these SGR and other issues much more emotional for physicians. And while we're working on these issues, we use it as an opportunity to remind our folks in Washington of how much cost has been cut, but how constrained that reimbursement environment really is for providers.
In June, the Office of Inspector General released a report that stated Medicaid agencies lacked oversight for drugs purchased under the 340B program. What do you think these findings will mean for the future of 340B, and what conclusions should providers draw from these findings?
Right. It was an interesting report. It certainly was one of the first times that we're seeing an understanding in Washington that perhaps the 340B program is being utilized beyond its intent, or at a very minimum, that no one's really policing who are 340B providers, are they really eligible, and so forth. So it's an important issue, I think, going forward, and the signal I take from it is that there'll probably be a closer eye on it, which I think is important to make sure in programs like that are being used appropriately.
Are payers aware of 340B and its potential impact on drug prices?
You know, Gina, they were not aware of it till recently, but I happened to be with our Managed Care Network Advisory Board this past weekend and asked a question related to that, and the vast majority were aware of 340B discounts. And the reason they were was it's a potential cost shift. Remember, those discounts really only benefit the entity. So neither public payers, so the government doesn't benefit from those discounts, nor do private payers benefit from those discounts. So private payers are increasingly aware and concerned that that growth in 340B is really creating other cost-shifting issues that really add to healthcare costs. And so it's clearly an issue that needs to be looked at to make sure it is being used appropriately.
The Affordable Care Act created pre-existing conditions insurance plans as a bridge to coverage until 2014. It was initially estimated that 200,000 people would be enrolled by 2013, but to date, fewer than 20,000 have enrolled. To what do you attribute this low rate of adoption?
Yeah, it is a very low rate. It's interesting because we know pre-existing conditions are a giant issue, and perhaps one of the most popular pieces actually of healthcare reform legislation was moving in 2014 to be able to obviously eliminate this issue, and this was a bridge of assistance to help with that. I think the low rate is partly confusion in the environment. I also think those policies came out initially very expensive. And so really, patients continue to look for other alternatives and to defer accessing some of those. And the government has responded. So effective July 1st, many of those premiums will be reduced, in fact, dramatically reduced in most states. So it'll be important to look at this one again at the back half of this year and see if we see people being able to get insurance that so desperately need it.
Do you think that this serves as an indicator of how the American public's understanding of healthcare reform is being rolled out?
It might. I certainly think it is a clue that we're going to have to do a lot of education, that perhaps everyone won't be able to take advantage of new insurance that comes out through those health insurance exchanges. And so we can't assume that we'll hit 2014 and suddenly the issues of the uninsured will go away. I think it's going to take a while for people to be educated, informed, select options, and then enroll in those options, and perhaps longer than many people would like for that to happen. But this will be a good learning curve for us all to understand what helps people that desperately need insurance be able to access insurance effectively.
From a broader perspective, what should manufacturers and providers be considering or doing now as it relates to healthcare reform?
You know, from a healthcare reform perspective, it's still an important time to have a voice in Washington, to monitor what's happening. A lot of things will continue to change. This is really the beginning versus the end. And so certainly everyone really needs to stay involved, because as the government looks for other ways to save money, there's a chance that good things could be cut, and then things that we need to have happen may not get funded. So we all really do need to stay involved with all the details as they continue to come out of Washington.
House Republicans continue to raise issues over health care reform. Given the Democratic majority in the Senate, the Republicans' concerns don't look to have a legislative impact. Can you discuss what the Republicans are pressing the Obama administration to do, and what actions, if any, might result from this?
Yeah, a number of really interesting plans have come out from the GOP. And the Ryan plan in particular might really just be a way to change the debate and discussion, and I think it's been very effective in doing that. It was radical thinking really to come out with alternatives that really would eliminate Medicare as we know it and move us to maybe a premium assistance or really accessing private insurance. And when I ask experts, they normally say that probably won't happen, but they do think it has helped to broaden the debate, which is very exciting because these are very emotional issues for many Americans. We all pay into these systems and we're assuming that they'll be there for us, so they're hard to talk about, but we're gonna have to make some kind of change in order to reduce those costs. So I do think the GOP's done a great job to be able to reinvigorate and really reopen the debate at a time from an economic perspective. We're gonna need to be able to do that. It's been an exciting discussion. It's certainly lots of emotion related to it.
Absolutely. Well, in late May, CMS issued a proposed rule that would allow physicians greater latitude in avoiding a 1% Medicare pay cut for now meeting meaningful use requirements in 2012. What What is your take on this? Good for physicians, obviously, but is this a situation where we will just keep moving the finish line?
Yeah, that delay is good news. There was a lot of confusion amongst the provider community about how to make sure that they weren't penalized. And the good news about some of these things is we want there to be carrots before there's sticks. And it was clear that the carrots converted to sticks perhaps a little bit too quickly for everyone. But I understand the sentiment that there's worry that we need to all move on to these systems, but particularly for smaller practices, I think that delay was actually a win and a very smart move before implementing cuts, particularly in an environment where we already have such constrained reimbursement. So that was very welcome news, and the physician lobby, I thought, did a very good job effectively describing that they weren't, not committed to these changes. It's just that they weren't already, and they didn't want those sticks or cuts to be implemented.
We continue to hear of issues related to drug shortages on older but critical medications, including some oncology treatments. What is being done to address these issues from a health policy perspective?
These drug shortage issues really are becoming, an immense issue, very emotional. It's primarily older generic drugs, but it includes some very important oncology drugs that are part of larger treatment regimens. And many of the shortages, in some ways, are just the normal law of economics as we understand it. Very few people are manufacturing these products, reimbursement for these products, and the cost of these products is actually very, very low. So it's not an environment that a lot of people are attracted to manufacture and to meet all the regulatory hurdles associated with meeting these products. So there's some good lessons for us as we look to generics to make sure that we create an environment where people want to manufacture these products. And the FDA obviously has increased its scrutiny of all manufacturers. So that has created some short-term issues as well in terms of supply and demand. The past month, we've seen two pieces of legislation move forward related to drug shortage. They're different pieces of legislation. There's a Senate and a House version, but both of them really get at reporting and increasing awareness of a potential shortage. So they have requirements for manufacturers to be able to explain to the FDA when they anticipate a potential issue, for example. I don't think they're going to solve any of the shortage issues, but it is helping to increase awareness, I think, of the issue. And for me, at least, I think it's also helping to highlight the fundamental economics, associated with this issue, which is how do we make sure that we haven't eked out so many costs that no one's making these products, particularly products that might be harder to manufacture or have higher risk associated with them. So we don't have anything that's passed and moved forward in terms of a bill, but we do have two attempts at legislation to at least raise the bar in terms of awareness of this drug shortage issue. And I think it's going to be here for a while. It may get worse before it gets better, but the FDA is certainly much more engaged on the issue, and I think more aware of how their actions can impact and even create short-term shortages.
Peyton, extremely timely and important information as always. Thank you so much for taking the time to join us today.
Thanks for having me.
And thank you for joining us. We'll be back soon with another all-new webisode. Until then, if it's on your mind, it's In the Know.